Hi, my name is Allison Sadowski, and this is my patient teaching plan. According to the U.S. Department of Health and Human Services in 2014, heart disease is the leading cause of death in the United States. I selected to do my health teaching plan on a 77-year-old male that was initially treated with pneumonia that was complicated by his history of heart disease. Due to the events that occurred during his stay, he would be discharged on new medications as well as changes to his previous medications. I initiated a teaching plan for my patient due to the changes in his medication regimen as well as the lifestyle modifications he needed to initiate. I would like to start my teaching plan presentation with a quote from Benjamin Franklin. "Tell me and I forget, teach me and I remember, involve me and I learn." My patient was a 77-year-old male that presented to the ER with wheezing and a productive cough. His blood pressure was 110/64, pulse 93, temperature was 97.6, and his oxygen saturation was 89% on room air. His respirations were 30. His white blood cell count was 10,700, and he had a low sodium at 139. His troponin was negative, and his proBNP was 8,839. His chest x-ray revealed that his lungs were hyperlucent and he had a right base infiltrate as well as cardiomegaly with his defibrillator in place. He has a history of ischemic cardiomyopathy, hypertension, hyperlipidemia, asthma, atrial fibrillation, and coronary artery disease with a history of an occluded LAD post-MI and COPD. His medication list included aspirin, atenolol, Lasix, simvastatin, and warfarin. He was admitted with right lower lobe pneumonia and was placed on Zithromax as well as Duomeds. It appeared that he would get a couple doses of IV antibiotics and then he would be discharged home and complete his regimen at home orally. Just prior to his discharge, his telemetry monitor showed 10 seconds of ventricular tachycardia. The discharge was canceled and cardiology was consulted. About an hour later, he was shocked 5 times by his ICD within a 10-minute period. Cardiology ordered an amiodarone drip, and during the initial bolus, he had an additional 8 shocks. The cardiologist then ordered a lidocaine drip, and that evening he again received an additional 5 shocks. The lidocaine drip was increased, and he was given 3 doses of IV low pressure IV. Cardiology then decided that he needed an upgraded biventricular ICD with a new atrial lead. He has since recovered and has had no additional shocks. He completed his antibiotic regimen while he was in the hospital, and he was also weaned off his oxygen. He was discharged on home medications of digoxin, valsartan, and spironolactone that were added to his previous regimen. A teaching plan was needed as he would need to adjust his medications as well as initiate some lifestyle modifications. The digoxin is a high-risk medication as toxicity can occur and needs to be monitored frequently. The Coumadin also needs to be monitored more effectively as his INR was 3.9 upon admission. His atenolol was increased and his spironolactone and losartan were added, which definitely would make him fall into the polypharmacy category. His wife was very supportive, and he and his wife were open to any lifestyle modifications they needed to make to maintain a healthy lifestyle. I set one broad outcome for my patient, which was that he will state at least 3 lifestyle modifications he should focus on for optimal future outcomes. I also set 5 specific objectives, which you can see there as well. I started my teaching plan with a review of his medication he was taking prior to his arrival. And I started with a Coumadin booklet, as I saw the biggest problem with his prior medications being his Coumadin. So I started with a Coumadin education booklet from Sanford in 2012. According to Glassine in 2005, the primary goal of anticoagulation therapy is to find the lowest possible dose that prevents propagation or reoccurrence of clot formation. A secondary goal is to find a monitoring schedule that balances the patient's safety against the discomfort, cost, and inconvenience of monitoring. I reviewed the importance of monitoring his INR as directed, as well as key areas within his diet that can affect his Coumadin absorption. I then reviewed his medication, including his atenolol that he was taking for his blood pressure, as well as heart protection. According to Laney, in 2014, beta blockers reduce heart rate and contractility and thereby reduce oxygen demand. Beta blockers increase coronary blood flow and myocardial oxygen therapy. His simvastatin he is taking for his cholesterol. I reviewed with him the most common side effect of this class of drug as being myopathies, which are characterized by muscle pain and weakness. Lastly, I reviewed his Lasix. He is taking this diuretic for his heart failure that is caused by his cardiomyopathy. He knew this medication quite well as he was familiar with the increased urination that it was causing. I did review, however, with him the side effects that this can cause, which are low blood pressure as well as dehydration and the alterations in his lab values. He was prescribed digoxin for his arrhythmias that he was having while he was in the hospital, and this could also have a dual effect that it could help his congestive heart failure. I reviewed the possible side effects due to the digoxin toxicity, including nausea and vomiting, as well as fatigue or visual disturbances. According to Ronaldo in 2013, 3 pharmacokinetic scenarios that could result in digoxin toxicity include accidental intake of digoxin, drug accumulation caused by metabolic and excretion impairment, and drug accumulation due to drug-drug or drug-herb interactions. Then I reviewed his spironolactone. I explained to him that this is an additional water pill that he would be taking that works in a little bit of a different way. This will help him with his heart failure, but again, he needs to have his lab values drawn to watch for any side effects he might be having. Valsartan was prescribed for his heart failure and blood pressure control. This medication can cause renal failure, and again, his lab values need to be monitored frequently for signs of this. Next, I reviewed some lifestyle modifications for my patient, and I used my facility's zone teaching tool for congestive heart failure called My Daily Treatment Plan for Living with Heart Failure. The first side of the tool is broken down into 4 categories: activity, diet, medications, and self-care. First, we reviewed activity for my patient, and for heart failure patients, it is important to encourage activity, however, balancing it with periods of rest to ensure no overexertion. Second, I reviewed diet for him, and for heart failure patients, it is important to review low sodium diet and food restrictions. First, I encouraged him to not add salt to his food, and second, I broke down and gave him 4 simple categories to stay away from, including canned foods, prepackaged foods, vegetable juices, and processed meats. And I did review this while the wife was present, as she did state she does all of the cooking. The third category was medications, and I got a pharmacy consult as I was reviewing the medications, but due to the possibility of any dose changes or medication changes, I did want them to review them just prior to discharge. And I also did provide the patient with a pill planner to encourage accuracy within his regimen. The last category is self-care, and I did review daily weight monitoring because according to Veroff et al. In 2012, daily weight monitoring is essential because dramatic changes in body weight are indicative of fluid balance issues. I also reviewed smoking cessation and got a consult because he was open to cessation and he wanted to get a little bit more information. So I got a consult for our tobacco cessation program so they could follow up with him. The second side of the tool is broken down into 3 zones, green, yellow, and red zone. Each section has 2 columns. The first column is the signs and symptoms or what the patient is experiencing, and the second is what the patient should do if they fall into that or the action. I reviewed the green section first, which would be like the good zone, then the yellow section, which was the caution zone, and if he was in that zone, he was to call me, and I did provide my name and number as the transition coordinator. And then the red zone is the medical alert zone, and he was instructed that he needed to present to the ER for any symptoms he was having in that section. I do have the unique situation in that I follow up with my patients with the transition program. I know that the teaching session was a success due to the follow-up that I had with him. His weight dropped an additional 4.2 pounds since discharge, and his INR has been much better controlled. when I called him to follow up with him, he did reference his zone teaching tool, or his green, yellow, and red sheet. This is great, as I know that he, again, was referencing it and applying what we had learned. His wife reviewed his diet that he had been having with me, and all of the choices sounded like great low sodium choices. He has also not smoked since discharge, and he was using a nicotine replacement gum when he felt it was needed. Overall, I think the session went very well. In his case, it was very complex, as he and his family were very, very stressed out due to the multiple shocks he received while in the hospital. He was able to grasp the concepts I reviewed, but more importantly, he was open to and willing to make changes in his lifestyle to be successful with his health maintenance. Here are my references, and thank you for reviewing my health teaching plan.